Morning, everybody. The task given to me is updates in liver transplant policy for SCC. With whatever experience I have in ILBS, I will try to justice to this topic. So, most important challenge in treating SCC is underlying liver dysfunction, and almost 90% occur in the background of the cirrhosis. So, whenever you're considering the treatment modality, you have to keep in the mind underlying liver dysfunction. And next important challenge, as we know, even the SCC at the even smaller size, they have neoangiogenesis and the hematogenous spread. They occur in the early course of the disease. So the multifocality is common in case of SCC. And that's why even after surgical resection, we'll get recurrence up to almost 50% of these patients. So basically, the liver transplant in SCC is for the tumor which is confined to the liver and which is not amenable to resection because of the underlying liver dysfunction or in a non-cirrhotic with multifocality or anatomical constraints. So you remove the whole liver and you replace with the new liver. So you are restoring the normal liver function, and it is widest resection or radical resection as oncological possible in case of malignancy. And also the liver transplant removes the additional advantages. It removes some detected and undetected foci of the tumor, and it restores the cirrhotic liver to a normal liver function. So whenever you consider liver transplant in SCC, you should keep some ethical points in your mind. Especially this is important in DDLT scenario, because liver transplant is a complex surgical procedure with post-transplant medical management, immunosuppression, and all that long-term follow-up. So it is a special medical treatment requiring allocation of the limited resources, that is in case of DDLT scenario. And some key ethical principles you have to follow regarding organ allocation, that is utility. Utility is basically in transplant you judge in context of the transplant benefit, that is long-term outcomes, that is additional gain in survival as compared to the other modalities or no treatment. So which is the population you are targeting, you have to maximize the post-transplant benefit. Justice is obviously, it is the sickest first approach, and you do fair prioritization, and not the least, that is autonomy, that is respect for the patient's informed decision. So you should always balance with equity and efficiency. So you should give the liver to the sickest, but still you keep in mind that utility should be higher. So if you see the papers in 1980s, if you use the transplant indiscriminately, the outcomes were very poor. Almost no patients survived after 36 months. Why the outcomes were bad? Because all these patients were very large tumors, multiple tumors, and they might have developed micrometastasis at the time of the transplant. Until in 1996, the Milan group from the Italy, they have restricted the size and number of the SCC, and they come out of the criteria with a single tumor less than 5 centimeter and no more than 3 tumors, and the size of the largest tumor less than 3 centimeter, no extrahepatic disease, and no macrovascular invasion. They analyzed the data only in 48 patients, and that has shown the excellent results with 5-year survival almost more than 75%. This still today, even almost 25 years later, it still today stands as a benchmark for the liver transplantation, and it has been validated in multiple studies. Even though there are long-term data on 5-year and 10-year survival, and the patients who are in Milan criteria, the 10-year survival reported in 96%, and which are outside the Milan criteria, the survival is poor, that is 63% as compared to the Milan within criteria. But that is a very restricted criteria. If you see the number of patients outside this criteria, almost 20 to 40%, and 20 to 40% number in case of SCC is very big number. So we are excluding lots of patients from the curative treatment. So after almost 5 to 6 years later, the UCSF group extended further the size and the number, just adding the 1.5 centimeter in the Milan's criteria. And the largest tumor size, single lesion with 6.5 centimeter, and 3 lesions not more than 4.5 centimeter, and the total tumor diameter should be less than 8 centimeter. And this also, the UCSF criteria was also analyzed in the small number of patients, that is 70 patients, and it has also shown the excellent results. Almost the 5-year survival is close to 80%. So Milan and UCSF criteria till today stands as the gold standards for the liver transplantation, and both the results were combined results were based on just 100 patients. So based on that, the UNOS currently, because have started giving the exception point for SCC patients, because SCC patients usually have the preserved liver function, so they get a lesser prioritization in the DDLT list. So this is the current allocation policy of the UNOS. If the SCC is within Milan, you evaluate this patient with CT chest and the CT abdomen, you rule out the vascular invasion and extrahepatic disease. You wait for the 6 months, and these patients allocated the not fixed score, but recently has been changed to the median MELD score at the time of transplant, depending on the region. For example, if depending upon the donor hospital, and it is based on the basically concentric circle on the donor hospital, you would take 150 miles from the donor hospital, and depending on the other patients in that area, you derive a median MELD score, and the points are allocated with median MELD score -3. For example, you are staying at Peninsula Villa in the US, the median MELD allocated for that region is 30, and the patient will get the MELD, which is the Milan criteria, it will get the MELD score of 27. So they are followed with every 3 monthly, and there is no additional points are given after that. If the patient remains within the criteria, then he will allocate the organ with deceased donor transplantation. If the patient is within Milan with good tumor biology, and if it is a decompensated patient, if you don't wait further and there is an option, if you directly go for liver allocation, or if it doesn't have, there is one option is of LDLT if there is a living donor availability is there. In US, typically these patients wait on 1 to 1.5 years. So to prevent this patient to go beyond the criteria, usually almost 80% of the patients, they receive neoadjuvant therapy. The most common therapy they received is TACE, followed by TARE and external beam radiotherapy. So what is the role of neoadjuvant or a bridging therapy? As I told, 80% of the patients in LTE, because of the long waiting time, they usually receive the exception points, and most commonly, they receive the neoadjuvant therapy, and most commonly is TACE. Recently, the use of TARE and radiotherapy is increasing. If you see, there was a landmark paper published in 2014, and even after that, there are multiple analyses, multiple meta-analyses. One was published in 2022, and recently also published in 2023. In bridging therapy, the exact impact on the waiting list, dropout and survival is unclear. But there is one important finding: the response to the neoadjuvant therapy has clear prognostic value, and that was it was published in AJT in 2014, has clearly shown the patients with TACE non-responders prior to the transplant, following the transplant, the recurrences was up to 20% as compared to the patients who have responded to the TACE prior to the transplant, where recurrence is less than 5%. Again, that downstaging therapy, so when you are going beyond the criteria, so it was not because Milan and UCSF are considered still restricted criteria, and because of evolving LDLT programs in Eastern countries, lots of people extend the criteria further because of the graft is private. So people started going beyond the Milan UCSF criteria, and they started the downstaging these patients within Milan criteria. This was same published from the UCSF group. The patients, this is the T2 imaging, means the patients within the Milan criteria, and these are the downstage patients from outside the criteria to the within Milan criteria. If you compare them, they come within Milan criteria, the 5-year survival is almost equivalent. And this has been validated recently by the multi-center study, and almost in 2009 patients, obviously 83% patients were downstage to the Milan criteria. Obviously some patients will not be downstage, and total 63 patients were transplanted, and they have shown the recurrence of almost as low as 7.9%. Even in this paper, they compared the TACE and TARE, so there was no difference in the time to downstaging, and also no difference in the waitlist dropout. So now the people started showing from the size and number. So now it comes to the response to the downstaging therapy has shown consistently positive results. So now people started using the dynamic criteria, that is with alpha protein, that is biological behavior of the patient, and we also assess the response to the therapy by the M-RECIST criteria. When assessing the response to the tumor, you only take the viable tumor diameter, you should not take the necrotic area. And this has shown the multiple studies that if the patient response to the alpha fetoprotein comes down, and with M-RECIST criteria, if there is either complete response or a partial response, these patients will have very good overall survival and recurrence-free survival following the transplant. And most important risk factors are there is a poor response to the downstaging therapy, and the AFB progression, that is fall more than 15 nanogram per ml per month. Even this was a recent study by Mehta et al. Published in Hepatology 2020. They compared the Milan UNOS downstaging criteria with also the Milan versus the all-comers. You do not restrict the tumors and you downstage them within Milan criteria. Patients who are downstage within Milan and downstage within UNOS criteria, they have equivalent survival to the Milan's criteria. And all-comers who do not downstage, they have poor survival as compared to the Milan criteria. So further, it is not just a morphological response, the tumor behavior by biological response is also important. So a few researchers has recently, the world has moved from the number size to the biological response. This was the recent study published by Neil Mehta et al. They have stratified the patients depending upon the AFB levels prior to the transplant, and there was no limitation to the number of SCC or size to the SCC, and they were downstage to the Milan criteria. Then also they see the response with AFB, and they're categorized into 3 groups, that is more than 1,000, which are responded from 1,000 to 100 groups. So patients who are responded to the from 1,000 to the AFB level comes to less than 100, they have better overall survival and recurrence-free survival. And more than 1,000 patients, almost they get recurrence up to 50%. So based on that, there was the protocolized approach has been started by the UCSF group. They have derived the downstaging criteria, that is up to 5 lesions. The sum of the diameter should be less than 8 centimeter, and AFB should be less than 1,000 at the time of downstaging. You do locoregional therapy depending on the availability, that is TACE or TARE, and if they meet the Milan criteria, and there also should be biological response, the AFB should come below the 100 prior to the transplant, and then the patient remains stable over the 3 months, you allocate the organ to them. So recently, based on this evidence, that is in 2019, the UNOS started giving the exception points to the patients which are also the downstage. So SCC within downstage criteria, when you downstage, they come within Milan criteria. Obviously, they will get similar exception points like Maiden-Belt score at the time of transplant -3. If these patients, they within Milan criteria, but they get decompensated and there is no organ availability, if there's one option is of LDLT, that is the living donor in the family, you can directly go to the LDLT. There are lots of fallacies in the selection policy, because if you take the 2 patient category, that is the decompensated patients with Milan criteria and the good tumor biology, plus patients who has responded, who require urgent transplant, versus the patient who has preserved liver function and within Milan criteria. So obviously, though both the patients will be given the same priority in the list. So if you, the patients who have in ideal scenario, the patient who have complete response, they should transplant, because complete response, imaging response doesn't correspond to the pathological response, and almost 80% of the patients will see a viable tumor. But in DDLT scenario, if you, there are studies showing that the patients with a complete response on imaging, if you compare with the patients who are undergoing transplant, their long-term outcomes are almost similar. Even the patient, they were compared with the recent RCT which was conducted by the Mazzaferro group, who downstaged the patient to the Milan criteria. We compared the group with that patient also, and their survival was similar to the patients undergoing transplant. Even you compare their dropout risk, the patients who are preserved liver patients, which are within Milan criteria, the dropout rate is very low, 5.5% at 12 and 12.4% at 24, as compared to the other patients, that is 20% and almost 30%. And based on that, recently the Mehta et al. Has derived one score that is based on size, number, the AFB levels, child status, and MELD score, and you can derive from mathematical calculation. Each category has been given points. If the waitlist dropout risk score is more than 30, that suggests most of the time it suggests the tumor aggressiveness, because in this group of patients they found only 12% of the patients the high score was because of their child status and MELD score. So if the score is more than 30, usually they have poor survival, and the 5-year post-transplant survival is less than 60%. Now, downstream staging, we have level 1 evidence that is recently published RCT in the Lancet in 2021. This was Mazzaferro group. There was 74 SCC patients beyond Milan criteria, no muscular invasion, no extrahepatic disease, and they calculated the 5-year estimated survival based on the Metro ticket calculator. Basically, it takes into account the size and number and the AFB levels, so that the expected 5-year survival should be more than 50% with preserved liver function. And they underwent the downstaging with local regional therapy, surgical resection, and systemic therapy. There was a 3-month observation period for stability, and they were randomly assigned into 2 groups. Interestingly, in this study also, almost 73% were successfully downstage, and 41% had a complete response. And what are their outcomes? The 5-year overall survival and the recurrence-free overall survival was excellent. If you take a 5-year event-free survival, which matters most, in transplant patients, almost 76.8% versus patients who did not have access to the transplant was 18.3%. And 5-year overall survival was 77.5% versus 31.2%, where patients didn't undergo LT. So now we have level 1 evidence for, though it was a small numbers, 23 in groups, still it stands prominent. So, still, if you restrict the downstaging criteria, still, if you take all-comer patients, there is some issue, because when you're taking, do not restrict the criteria, you take all the patients for downstaging, they will have more waitlist dropout, and the downstaging response in these patients will be less as compared to the downstaging criteria. And this was a recent study, that the US multi-center study, the 82 all-comers without vascular invasion and metastasis were compared versus 23 patients meeting the UNOS downstaging criteria, and in all cases they attempted downstaging to the within Milan and confirmed stability prior to the transplant. See, the probability of the downstaging was higher in patients in the downstaging group, and in all comers it was 20% less. But if you see if you downstage them, even in all comers within Milan criteria, and you transplant them, few of the patients do survival was very good, as equivalent to the patients who were downstage to the Milan criteria. So some of the even all comers also we can downstage to if they have good tumor biology, and if you transplant them, they will also get a good survival as equivalent to the patients undergoing transplant for Milan's criteria. So how to identify the upper limit of the tumor burden? Because somewhere you have to, because Milan and UCSF, you cannot put a one line that below this you transplant and above this you don't transplant, because the world has moved from the size number to the biology. So it was initial effort was made by that same Mazzaferro group. They had the Metro Ticket 2 model. Basically it is based on the number and size of the tumor and the AFB levels. Obviously, when you increase this number size, the survival is poor. Obviously, in the higher AFB levels, survival is poor. But if you see, even your recent consensus is that the expected 5-year survival, if it's getting 50 to 60%, even with a higher tumor number, and if the AFB responds to the downstaging treatment, this patient can be transplanted. And what is the upper limit of the tumor burden beyond which the transplant becomes a futile business? So recently, even the Jan Lurett group has derived, it was basically Western and Eastern population, it was more than 1,000 patients, and they derived a downsstaging model. And in that, they've taken this, the tumor size, nodules, and the AFB. They are categorized into 4 things. And basically, these yellow dotted areas are basically Milan's criteria, and these horizontal lines area are the downstaging area with the cutoff based on the tumor size, number, and the AFB levels. And they compared the results with the Milan in, Milan out, UNOS downstaging, and all comers. And if you see, when the patients go outside the downstaging criteria, almost 5-year, the mortality becomes above the 30%, and that is not acceptable. And beyond the downstaging criteria, beyond this criteria, they have excellent survival, and their 5-year mortality is less than 30%. So you can push the limit further recently because immuno-oncology is evolving in SSC, and lots of centers are using immunochemotherapy for in combination with locoregional therapy. And this was recently proposed algorithm by the Neil Mehta et al. That is published in Clinical Liver Disease 2024. So patients which are the high risk factors, that is high tumor markers which have recurrent disease after complete response to the downstaging therapy or persistent residual tumor to the downstaging therapy, you can use this immunotherapy and further downstage, then there will be washout period, and after that you will transplant them. This will look fascinating and look interesting, but there are lots of issues with this immunotherapy modality I will come to later. So, because simultaneously in the Eastern world, because of the most dominant transplant modality is LDLT, and the criteria were evolving. Every center was going beyond the criteria, and this was the standard Kyoto criteria. They have number less than 10 and the size of the tumor diameter less than 5. And they found the PUCA. They have taken a PUCA as a biological behavior of the tumor, that is a level less than 400. And they also shown that PUCA, especially in AFB negative patients, the PUCA has very good correlation of the biological behavior of the tumor, especially it correlates with the tumor differentiation and the microvascular invasion. And they have proven that if the PUCA is more than 400, almost the microvascular invasion has been found in 60% of the patients, and poorly differentiation tumor has been found close to 40% of the patients. And the PUCA is an important parameter of the tumor aggressiveness involved in angiogenesis, and it is a good predictor of the microvascular invasion and the recurrence. And they have found that they analyzed the patients meeting their criteria, and the patients who were met the criteria, the 5-year recurrence rate was 5%, as compared to the exceeding the criteria, the 5-year recurrence rate was close to 60%. And the world has moved from the, as I telling repeatedly, that more numbers to morphology, and there are multiple criteria. Initially it was based on number and size. There are different cutoffs for the different centers. Toronto has come up with the tumor volume, and depending on the microvascular versus macrovascular invasion. The world has moved from the morphology to the tumor biology. You can see people are taking the biopsy findings, but biopsy it has issues, that is biopsy-related complications, and there may be heterogeneity in the tumor upon the tumor differentiation. And there are lots of biological markers we are taking, that is static markers and dynamic markers. In static markers, there are different cutoffs in the literature for AFB, PUCA2, and even there are papers with using combination of these two. And there is a recently published in Journal of Hepatology 2023, they have taken DCP with AFB L3 fraction, which is bound to the lens culinaris agglutinin. It has 95% specificity for the tumor aggressiveness, especially the small tumors which are less than 3 centimeter. And if you combine both the things, that is DCP more than 15%, sorry, the AFB L3 fraction more than 15%, and the DCP more than 7.5 nanogram per ml at the time of the transplant, and they are highly predictive of the early recurrence, and they have found almost recurrence of 30% at 3 years. So we can base using combination, we can also exclude some of these patients, and we can super select out these patients for the transplantation. Also, the people are using the dynamic markers, that is AFB, PUCA, fall after the response to the therapy. There is a neutrophil to lymphocyte ratio, platelet to lymphocyte ratio, and recently the PET uptake has taken, especially tumor to the liver ratio. That is, different studies have come up with the different cutoffs, that is 1.5 to 2.1 and 5. There are also predictive scores. There are some static scores and dynamic score, that is French model, which takes into size, number, and different AFB cutoffs. Metro ticket I already explained. The moral score was basically a mathematical equation come with the AFB and PUCA2, which was derived by the Korean peoples. And the retreat score takes into size, number. This basically takes on the explant pathology and AFB levels. Recently, the dynamic criteria has come, that is New York, California criteria, and it has been validated in large population, that is published in JAMA. And it takes basically size, number, and response to the downstaging therapy. They are categorized in different AFP cutoffs, and depending upon you stratified the patient into low, mid, and high risk score, and you can categorize the patient which will develop high recurrence versus low recurrence. And see, in SCC management, there are two factors basically. One is the tumor control factor, one is the time control factor. The tumor control you can have with the local regional therapy. You can assess the response with combination with M-RECIST criteria, tumor markers, and the PET avidity. And the time we can control with depending on the availability of donor, that is DDLT versus LDLT. In LDLT, we have a wider selection criteria in LDLT.
Can you summarize, Nilesh, now? We're running out of time.
I'll just finish in not much slides. Okay. So if you see the literature, there are almost 50 plus scores in the literature, and all they are not satisfied with the Milan and UCSF, and this criteria allowed up to 60% of the more patient to access to the transplantation. And majority of these new criteria, they have reached overall survival of 70 to 75%. And if you see the recurrence-free survival within Milan, it is very good. Milan out criteria is more than 50%, and the new criteria out was very bad. But whenever you consider this criteria, you should respect the ethics of the transplantation, that is justice, equity, and the utility. And you should not forget the effect of LDLT in case of SCC. There are two papers from the Journal of Hepatology and JAMA, which have shown that LDLT has markedly decreased the intention to treat mortality by almost close to 50% by eliminating the dropout risk, and has a better increased survival rate as compared to the DDLT even in advanced SCC. And there was overall gain in survival of almost 20%, and it was remained persistently even after propensity score match analysis, which matched different factors. Even our center has also done a reasonably good job and published recently with a protocolized approach, which has shown the overall survival close to almost 85% and recurrence-free survival of 83.3%. So whenever taking in the LDLT, you should always, even in my last presentation I shown this slide, that you always consider the benefit and risks of the LDLT. I'm not going to repeat, I will skip this slide. So this was an important paper to extend the further criteria. This was a moral score, and they found a cutoff of 314. And in this paper, interestingly, they have 82 patients were Milan out patients were with PBTT, and they had a local regional therapy. And after the response, they found that the transplant, the risk of recurrence was very low. And from that paper, there was lots of interest started coming in patients with PBTT. We have major experiences from LDLT from Korea, and there's one DDLT found. And this looks fascinating that but the follow-up is very small. The median follow-up, if you take, is hardly 30 months, and they have shown the survival almost 3 to 5 years survival. Majority had 3 years survival, high recurrence. And all the studies have shown response to the downstaging, not responding to the downstaging, Milan out criteria, and the VP poor patients were doing poor. So you should interpret the results with the care in the context, because they're all a retrospective study and there are lots of heterogeneity, though they are from the high volume centers, and they have taken the neoadjuvant treatment. The results should be analyzed, the availability of the neoadjuvant treatment, and the expert liver radiotherapist. So this was recently, the Asan Medical Center has come with strategy with SCC, PBTT. You downstage them and you stratify the patient with the SNAP score, that is basically size, number, AFB, PUCA, and you take PET avidity. If the SNAP score increases, the recurrence risk also increases. And they have taken an operative strategy, that is non-touch recipient hepatectomy. You do a porta-first approach with early portal vein division, and you in VP4 you resect the portal vein and put a jump graft. And they have found excellent results with the very small recurrence risk. So you need to learn the important lessons from your past and actual experiences. You should make the correct diagnosis and extent of the tumor. You should study the tumor morphology, PBT nature. It is important that you should exclude the false positive patients, because in SCC in PBT blunt thrombus does not always correspond to the tumor thrombus. You take the full imaging potential, and in bilateral VP3, that is both right and left portal vein branches, and VP4, that is main portal vein, the poor patients, the patients will perform the poor with downstaging therapy or transplant. It can be estimated with the help of SNAP score. We don't have the answer right now. You should do adequate preconditioning with the local regional therapy. You should assess the response to the downstaging, and should have optimal surgical strategy. Whenever you are interpreting the results, there are results of highly centers from the LDLT. In DDLT, you have a scarce organ pool, competition with non-SCC patients, and in case of SCC PVTT, it should be very difficult planning, especially from diagnosis to LT, and this downstaging to LT in Western cohort has shown very long time. Also, you should take into account whenever you extending the criteria further, whether you will manage the recurrence. Recently, the management of recurrence also has improved. You need to have long-term follow-up, which matters the most, and the minimal acceptable survival should be more than 50%. And we should have, there is a need for further prospective, which is well-defined protocolized studies needed. So transplant, but you always
we need to summarize
some, because important is post-transplant immunosuppression. Whenever you go beyond the criteria, obviously the risk of recurrence increases, and because recently the immunotherapy is coming, the lots of patients are developing rejection following the transplant, so are giving higher immunosuppressive load, and that increases the oncogenic risk. So immunosuppression is always pre-tumorigenic, and it is an important modifiable tool in the immunosuppression handling and monitoring. Whenever possible, avoid immunosuppression load, use of mTOR inhibitors, and you decrease the CNI dosage, and you can use the TAC monotherapy. And this was immunotherapy. This will look fascinating, but there are lots of reports are showing the post-transplant hepatic necrosis.
Nilesh.
So conclusion is basically what matters most in transplant is disease-free survival, that is, and transplant benefit. You should select the patients based on the substantial benefit from the transplantation. The subgroup is not static, because transplant and immuno-oncology is evolving. You should refine the criteria timely as with the development. So it should be refined selection criteria based on improved understanding of the cancer behavior, improvement of the neoadjuvant and adjuvant treatment. And in most cases, till today, is the response to the neoadjuvant treatment is taken as a biological marker, and it has helped in improving the outcomes. So now there is active research in going SCC biomarker, that is protein expression, circulating DNA technology, and tumor RNA, which can be detected with the liquid biopsy, but is not yet validated in SCC. It can help in better understanding of the tumor biology, that will improve the risk stratification and selection of the therapy. And evaluation of the systemic therapy, that is immunotherapy, also will hold promise. This is IL-based data. Till today, we have performed 90 patients, SCC patients underwent transplant. The median age was almost 52. Male was predominance. The median MELD score was 17.2. Almost 84.2% were decompensated as compared to the results from the other centers. Ethanol and NASH were also upcoming as a major cause of SCC, and almost 40% patients received pre-LT therapy. And there were 39 patients, 40% have had a microvascular invasion. The complete response was seen in 60% of the patient, and partial response was seen in 31% of the patients. And with preoperative imaging within Milan were 63, within UCSF 70, and up to 7 criteria was 75%. And the recurrence was seen in 9, that is 10%. If we compare recurrence versus no recurrence, though in no recurrence group we have performed more patients with more than 10 tumors, but in the recurrence group they had a higher microvascular invasion, there was a higher retreat score, and there was shorter time to the transplant, and that is a most important factor in LDLT. And they have higher PET habit tumors. And whatever the tumor biological, we assess the biology of the tumors with response to the downstaging therapy. And this was the AFB and PUCA before downstaging and after downstaging. And this was a 5-year survival and disease-specific 5-year overall survival, recurrence-free survival. And the 1-year survival 93%, 3-year is 86, and 5-year is 81.5. The recurrence-free survival was 81.3%.
You should give the number of patients and the table below.
Yeah, yes, sir.
At risk and at 5 years. It doesn't mean Nilesh.
Thank you.
You did a lot.